you. It's probably not everyone's idea of how you'd best want to spend a Wednesday in winter in Manchester, but maybe it is for some of you. But a huge thank you, because it's great to have so many people here. My name's Ruth Beattie. Your agenda probably says I'm Olivia Butterworth. I'm not. Olivia can't be with us today, but I'm a bit of a stand-in. I work in the Public Voice team at NHS England with Olivia. Our job here today is really to facilitate this conversation. So it's a conversation between you, the Care.Data Advisory Group and the Care.Data programme. And it's really, our job is not to be experts in Care.Data. We've got loads of people that know the facts. But what we want to do today is make sure that you can have a conversation and your voices are heard. A little bit of housekeeping. We're not expecting a fire alarm, but if we do hear one, it's out of that door and turn right down the stairs, just outside the door. Toilets are also out of here and on your right, and there's some right at the other end as well, because I think there's only 3 at this end. We've got quite a lot of facilitators in the room today, and their job really is to help you on your tables, to guide you through some of the discussions, particularly when we have the table conversations later. If you're a facilitator, can I just ask you to stand up so people know who you are? So these are the people that are here to help us through this conversation today. Couple of little practical bits. We really want to capture as much as we can from today. On your tables, there are some sheets of A5 paper. Any ideas, suggestions you have as we go through the day. These 2 walls are sticky, so if you write on these, stick them on, it means we've got a really good record for when we write the report. Today is being webcast. I'm not actually quite sure whether the webcast, it has started, so hi to anyone that's watching that isn't here. If you really don't want to be shown on the webcast or be videoed, this table over here is out of camera eye shot. So move to that one. I would do that now. We are tweeting throughout the day, so if you're a tweeter, the hashtag is #Care.Data. There'll be various people tweeting bits of the conversation and enabling people watching the webcast to ask questions and to contribute to the conversation. So we'll try and bring as much of that into the conversation as we can. Very quick run through before I hand over to Kieran, who will talk about the advisory group and what's happened before today. In terms of the programme, Tim Kelsey, National Director of Patients and Information, I forgot his job title, is going to do an opening presentation after Kieran's welcome, which will give some of the factual content, background to Care.Data, what the programme is, and also some of the issues and concerns we've heard so far and what we've done to address some of those. We'll then move into a bit of a panel discussion, so between the advisory group and the Care.Data programme, have some of those conversations and give you a chance to ask some questions. And then we've got some table discussions, which will take the last half hour. So hopefully there's plenty of time for you to talk to the advisory group and the programme really about today. So, Kieran, can I hand over to you?
Thank you very much. And again, thank you for coming and giving your time. I'm sure you'll remember this project had programme had a slightly sticky start. And in my spare time, I'm a non-exec of NHS England. So I was asked by the board of NHS England, would I chair an advisory group to, talk to people, think, and then do some quality assurance on what the programme was doing. So myself and Phil, who's here with me, we are not the programme, we are the advisory group. What we decided to do was, rather than have a bunch of experts sitting in a room meeting every 2 weeks and only do that we would also make sure that we had a series of conversations around the country where we're able to say, here are the kinds of things we're hearing, here are the kinds of things the programme is telling us, is that making sense to you? So that when we go back and have our conversations with the programme board, that we're able to say, well, actually, that makes sense, because that bunch of people in Manchester, they kind of felt the same way. Or we can say, actually, that's completely different to what those guys were saying. Now we need to dig a bit deeper. So we're trying to be the quality assurance process. The group that does meet every month or so now is really people with an expertise in some aspect of the kinds of things that this programme is trying to address. So until recently, I was the chief exec of Macmillan. So my interest was saying, how can we use data to improve services for people with cancer? Phil is an expert in privacy and confidentiality, works for an organisation called Med Confidential, so he comes from that point of view. We have President of the Royal College of Psychiatrists there who comes from a clinical point of view. So we try to have all the voices in the room and all the different opinions. But as I say, what we didn't want to do was just sit and have deep thoughts amongst ourselves. What we want to do is make sure that we play the conversation we think we're hearing. The first session we had was in Peterborough, where we said, these are the things we think are the problems. Is that what you think? The second one we had in London was saying, OK, now these are the principles of what might look like a solution to some of these problems. Is that making sense? And the third conversation here today is saying, for some of the big issues, here are some of the detailed proposed solutions. Now, what do you guys think? So the table conversations will be picking up 3 of those issues, and what we would like to know is how's that sounding to you? Does that make sense? And the thing we'd like to do first is invite Tim on behalf of the programme to do a bit of background, because clearly, you know, some of us have been steeped in this for the last 6 months. Some people have been in it for 2 years. Some people, you know, sort of first heard about Care.Data last week. So just a bit of a levelling, bit of where is the programme today, what's been happening over the last number of months, and Tim will talk us through that. And then we'll open it up for Q&A, if that's okay. Make sense? Again, thank you for being here.
I think we're going to get a short video first, which kind of sets out the overarching. Is that right? We're going to get a little video. Okay.
Every time we go to hospital, the NHS collects information about us to help improve care for everyone. For example, our information is used to check the safety of different hospitals, to study the quality of care across the country, and to help plan new health services. We've all been benefiting from information like this for decades, but at the moment the NHS is missing information about much of the care provided outside hospital. This is a problem because it means no one really knows how well all the different parts of the system are working together. To help tackle this problem, the NHS is going to start collecting information about the care provided outside hospital, and we're going to collect some information about hospital care that's missing at the moment, such as details of tests and medications. Together, these improvements will provide a better, more complete picture of the care being delivered. Soon we'll know about the quality of care that patients receive as they move between all the different parts of the system. We'll see where the NHS needs to invest more in different parts of the country and in treating different diseases and conditions. We'll find out where the NHS is providing excellent care, but also where there may be local problems that need to be fixed. However, you have a choice about taking part. If you are happy for your information to be used like this by the NHS, by researchers and other approved organisations, then you don't need to do anything. But if you'd prefer not to take part, just contact your GP practice. The NHS believes your confidentiality is extremely important, and we will always comply with all our legal duties to protect your information. This is an opportunity for each of us to help the NHS deliver high-quality care for all. For more detailed information, go to www.nhs.uk/care-data.
Great. Well, thank you. That's great. Fantastic. Well, thank you very much. So, yeah, my name is Tim Kelsey, and I'm what's called the National Director for Patients and Information. And one of the most important responsibilities I have is to fill those gaps in our knowledge about what happens to patients in our NHS. And I think people will be very surprised when they realise how little actually we know about the experience people have in health services and the degree to which, as a result, we can't do things that are very urgent to improving the quality of care for those people. So just to give you one example, right here, right now, I couldn't tell you, nor could anybody else, how many people are being treated in England with chemotherapy and to what effect. We don't have that number, we don't know the numbers, and yet if we did, we would be able to assess the degree to which they were receiving the right kind of treatment in the right sort of a way. And we've got some really big problems. We've got problems like the fact that we know that there are a surprisingly large amount of people who are being diagnosed late with, say, bowel cancer in the A&E department, when what we really want to do is to find their illness much earlier, before they get into an emergency situation, and be able to work out plans, or have their GP work out plans for them at a much earlier stage. And we know that when we do find people earlier in the course of their disease, they quite often have a longer life expectancy as a result. So to some extent, I think many people in England think that we know all this. And so one of the very difficult things about this programme has simply been to be honest about the fact that there are big parts of the service we do not know very much about. And as a result, we are struggling to improve it to support GPs and others to do their very best to support their patients. At heart, that's what this is about. So Care.Data is at heart about improving the way in which services can be improved pretty much right here, right now, for patients, that we can do something about things like late diagnosis of cancer. We can improve the survival rates for people with heart disease, again, many of them diagnosed late in their condition, and understand how we can get to those people sooner. It's also about helping us plan services. So we know, for example, that there are lots of, well, in one level, services in the wrong place. We know that the kinds of services are often offered to local communities are not quite right for the needs that they have. And we know that in some cases those services are provided inefficiently, that they are not providing real value to us as taxpayers, as well as high quality care for us as patients. And again, we can't plan for services that offer a seamless experience from diagnosis through treatment in a way that we will all want, without access to data about the whole experience of patients in our NHS. And the third big reason for doing this programme relates to the vital importance of both understanding how current medicines and treatments deliver real value for patients. And I'm afraid to tell you that there are quite a number of medicines that are currently being prescribed by GPs that we suspect do not offer much value to their patients, but we do not have the data covering the whole population adequately enough to be able to really identify which ones work and which ones don't. And perhaps equally importantly, we need to think about the future. We need to think about our children, and we need to work harder to make sure that the experience the NHS is currently having is a basis on which we can start developing new medicines and treatments, and understand how to unlock the power of some of the new science that offers so much to us and our children as patients. And I'm thinking here particularly of the new sciences like genomic science, and there are other ways in which clinical scientists are opening up new horizons for ways in which patients can be treated in the NHS. So broadly, three core reasons: supporting improvement in quality here and now by filling the gaps in our understanding of what goes on in the NHS. Secondly, helping us plan services more appropriate to what local communities actually need. And thirdly, to help us develop new medicines and treatments and understand which ones currently do and don't work. I'm standing in for Eve Roodhouse, who's actually the programme director. I'm what's called the senior responsible officer for Care.Data, but Eve unfortunately is not well, so I hope you'll excuse me as the stand-in if I'm. Hang on, we're going the right way. So this slide kind of summarises what I've just said, and at the moment, to be clear, the programme is looking at nothing more than linking data about the experience of people in general practice with data we already have on their experience in hospitals. And on that point, Phil and I had quite a memorable debate about this on the Today programme some time ago, but for about 25 years, we have been using data on hospitals to, I think, very importantly help us understand which hospitals are providing care that we would consider to be of a high quality and which are not. And when we find a hospital that is not, we are able, on that basis, to intervene and to improve the service provided. And perhaps most importantly, that occurred, that data was used as part of a variety of different indicators to demonstrate that there was potentially a problem at Mid Staffordshire Hospital. And it was one of the things that drove the regulators to identify the issues there. And we don't have the same kind of tools for surveillance in general practice. So one of the first phase of this project is just to link data in general practice with data in hospitals. Now, because we know that we did live in a digital age, and although the NHS, as I'll describe in a moment, will do and is currently doing everything it can to set what you might call an NHS standard of vigilance. You know, confidentiality is possibly the most important single characteristic of the relationship between a doctor and a patient, and must and cannot be compromised by whatever benefits a program of this sort might bring to patients. But we can't absolutely guarantee that will be the case, because in this digital age there are all sorts of risks that haven't existed before in relation to, you know, people hacking data and so on and so forth. So all we can do is do our absolute best. But because we can't guarantee it, one of the other really important things about this program, which at the time it was launched caused quite a lot of confusion, was to say that in the end it's got to be the patient's choice as to whether they are prepared to share their data for what I would describe as these important benefits. And as a result, we introduced something called an opt-out, which enables people to decide, if they do not want to participate in this program, that their data will not leave the general practice and will not be part of the insight that we subsequently have into local services. Now, we think that that's a person's right. Obviously, we hope they won't exercise that right, because the more data we have on what's happening in the NHS, the better will be our ability to support GPs and others in delivering the right service for the right people. But that's a matter for individuals. So, in a way, the importance of tonight and the importance of all these conversations we're having at the moment is to try and work out how best we make people aware of those rights, but equally, hopefully make them understand that if they do share their data, it's an act of altruism, it's an act of it's a gift which can have a very profound effect on helping other people and themselves as well, potentially. Again, I won't go through these examples because I think perhaps I've covered that off, but there are lots of examples, and perhaps of ways in which already, actually, in local contexts where some of this data is currently being shared, real benefit is accruing. And actually, there's one example which isn't here, which I'll just mention, which is a very good friend of mine runs, I'm sure Amir will know him, runs the local, a big general practice in health centre in East London in Tower Hamlets. And they have been sharing data between different general practices in order to understand how they can improve immunisation of children, particularly in very disadvantaged ethnic minority communities. And there was a point in time about 5 years ago where they had incidence of childhood diseases that were of the 19th century. They were essentially, immunisation rates were so low that there were really disproportionately large numbers of people suffering from the kinds of diseases that in most of our country we have more or less eradicated. And in order for that to be achieved in Tower Hamlets, they needed to get the immunisation rate up to what's called a herd level of immunity, where basically the entire community is continuously immune to these diseases. And so they shared data in order to understand how best to target their services at the most affected communities. And in the space of 2 or 3 years, they've raised the level now to herd immunity in those areas. So in a very meaningful way, in Tower Hamlets, the act of data sharing has quite literally saved lives. It has protected children from lifelong disability. It's a very important, real effect. Have I gone the right way? Yeah, okay. So this broadly describes what happens to your data if you were to be as generous as to allow the NHS to have access to it. And essentially, it goes from the GP practice into a body which the NHS has set up to manage these data flows, and then through a very rigorous process of independent and transparent assessment, in in de-identified formats, in ways that can't readily be re-identified, to approved users. And for the very large part, the people who will be using this data will in fact be, of course, local hospitals, local commissioners, NHS organisations. But we do want to also be able to give this data to appropriate researchers, organisations like looking at the development of new medicines, new treatments, trying to understand patterns of disease in our society as well. But one of the things I'll point out in a minute was a very big concern when we first launched this programme was that we weren't being clear enough about the safeguards for who got access to your data once you'd given your permission for it to be made available. And so we think we've listened hard to that, and we've made some changes to the law, and we made some changes to other operating procedures across this process, which we think does provide much greater transparency and in fact makes it now illegal for this data to be used for any other purpose than health and care benefit. And again, we need to work very hard on defining precisely what we mean by that. But what it definitely does not mean, and this is the will of Parliament and of this government, which needs to now, of course, be reflected in the operating procedures, is absolutely not for purposes connected to things like insurance or junk mail. And these were issues that were raised by Phil and colleagues, quite rightly, as it turns out, earlier this year, which I hope we are now making progress on providing reassurance over. So we've been involved since February, when we brought the programme to a stop, frankly, in order, not that we didn't want to proceed with it, but just to listen harder to what people were worrying about. And we've had we've met more than 3,000 people, or almost 3,000 people, as you can see here, in a whole range of different meetings and events right across the country, engaged with all sorts of stakeholders, national bodies and others, charities, to think through the issues. And we now feel we're in a position to kind of report back. So what we're doing over the next few weeks is publishing some material which I hope expresses our thanks to all those people who've taken the time to tell us how we might be able to get this right, but also to put in place the kind of safeguards that you've been telling us are absolutely necessary. So we are going to be publishing this document in the not too distant future. So I'm not going to go through all the details here, but because it just goes on for too long. But we'll make sure you all get a copy of it when it is available. But just to give you the kind of a bit of an overview of the sorts of things that people were raising, as I say, people were very worried about who would get access to their data, that we particularly anxious about the idea that somehow this might be used to affect the setting of insurance premiums, for example. There was a particular concern around that. There was another concern that somehow this might find its way into product marketing or junk mail type applications. They were very worried about the risks. The point I made really about the fact that there are risks, and I think people really wanted us to just be very frank and open about that fact. We're all adults. We use the internet, some of us at any rate, and in the era in which we operate, those risks need to be minimised, but we can't guarantee completely that they will never exist. So hence the opt-out and so on. There was quite a bit of confusion about the difference between what we're asking for here, which is for patients to consider sharing their data in order that we can look at the experience they have had historically over time in the health service, as opposed to data which is used for their actual treatment at the point that they receive care. And in the jargon, we call the latter of those primary uses, i.e. a doctor at the bedside accessing your record in order to administer a medication to you or something, as opposed to the use of data sometime after you've probably had your care episode, in order that it can be analysed for all the benefits I've just described, and we call that secondary uses of data. And I think people, again, in the first iteration of this programme got confused, because actually I don't think our material, our literature, the way in which we described it was successful in helping people understand that if they did choose to opt out of this programme, it didn't have any impact at all, and certainly won't, on their eligibility for care services in the NHS, nor on the ability of their doctor to treat them appropriately at the time they need care. Communications with patients on their right to opt out. So this opt-out is a quite complex issue. It's new. There's nowhere else has introduced such a right to patients in relation to their medical data, and people complained that we were overly complex in the way we explained it. So we've done a lot of work to reduce the complexity, not just of the way it's explained, but actually of the way it operates as well. I'm sure we'll get into that today. The benefits case we weren't clear about, again, perfectly legitimate criticism. And then the other thing, which is in a way a more internal question, which is GPs have a big enough workload. How are we going to support them so that they don't just collapse under the burden of all the various things they're asked to do? And that's been a very important part of what we are now dealing with. So I'm going to race to the end of this now because I'm sure many of these issues will be discussed. But I just want to get to actually what we're doing today. So in response to all the feedback we've had, and the crucial need for us just to start testing a different approach, having put in place new laws to ensure better safeguards, having clarified the opt-out, having worked out, I hope, a better way of explaining the benefits, and also being more open about the risks, we decided that the best way of doing this was to, in a very transparent and open way, work with, as it's turned out, with 4 local health economies, local areas, broadly covering about 250 GP practices, to start to redesign the programme. So we're now in this phase of co-production, working with not just the GPs themselves, but also with local patient groups, health watches and others in those 4 areas to start really understanding whether or not we have got to the right place. And so we are spending a very detailed amount of time looking at materials like these, understanding whether or not they make sense to people, are they explaining the right things, and essentially doing what I'm afraid public services on the whole don't do, which is just being honest that we got it wrong and trying to start again, working closely with local health economies in order to try as hard as we can to get it right for all the reasons I've just said, because the longer it takes for us to get it right, the more people will not be benefiting from what we could be helping them with. And then just finally, we will not be proceeding to any kind of national rollout of this programme until we are absolutely satisfied that we have designed an approach for patients and for GPs which is clear, which communicates properly the benefits and the risks and the rights to opt out, so that when we do go to national rollout, should we get that to that point, we can be confident that we've learnt from what happened before. And the process, which is briefly outlined there, is there's a very eminent individual who has been a long-standing guru in the area of confidentiality, Dame Fiona Caldicott, who has recently been appointed the National Data Guardian, and she will be overseeing now independently the degree to which she feels we've reached that standard, along with a range of other voices, including, of course, Phil and Kieran's advisory group. And so once we have got to a consensus that we feel we are ready to roll, that will be the point that a decision is taken. But we're not rushing it. We are going to take our time to make sure that we are in the right place. So I'm going to leave it there, but hopefully that gives some useful background.
Thanks, Tim. I'm sure there's probably lots of questions in the room that you want to ask, so just keep hold of them for probably 10 minutes. Because before we move on to that, I'm going to ask Kieran and Phil on behalf of the advisory group just to give some of their reflections and feedback, what they've been hearing over recent months, what their current challenges, questions are for the programme, and ask Tim and Janet King, who's Regional Head of Intelligence for the North in NHS England and does a lot of work on Care.Data, to give us a bit of a response and reaction to that.
People watching on the webcast couldn't see the slides, so we'll work out how to email them to them or something similar. Put you on the spot first, quick. Phil, you've been in from the beginning of this. How do you feel things are, if that's not too open a question for you?
Right, well, I mean, as you say, we're in a process. As Tim has laid out, there are certain things that are meeting what MedConfidential said from the start should be the basic principles, that whatever's done with patients' data is consensual, safe and transparent. And Tim's, in his talk has actually pointed to several of those things. We're not there yet. You know, the law, the changes in the law still need, the rules, if you like, still need to be laid finally before Parliament, so we can see how that independent oversight is actually going to be managed. We need to define things. Tim mentioned that this is going to be used for the benefit of health and care, but there's also bits like, you know, the promotion of health, which leaves an opening, as we still see it, with the way that things are structured, where you know, certain companies still would be able to get access, and there still are things such as commercial reuse licenses. So we need to nail down the detail. Yeah, this is so important. You know, and no one is disputing that there are huge benefits to be had here. The problem is, certainly with the sort of, you know, rocky start that this programme had, is that to get, maintain and build public trust, you actually need to nail all of these things. So, for example, something Tim didn't mention, but you know, we know about, in this Pathfinder phase, the undertaking has been given to Parliament and other people, that the information that's taken from your GP practice and the linked information with the hospital data will happen inside a secure data facility. Yeah? To minimise the risks of things, adverse things happening to people's data, you can do something which is not give out copies of it, yeah, and only allow, you know, the approved users in the first instance to come to this thing, and over time, as people can prove that they have similar levels of security, to be able to, you know, maybe access a copy, but not take away individuals' data, and that's the crucial thing. There are promises that can, you know, be made, and these are good things, but we want to see them in place. The crucial thing for Med Confidential is, what are patients being told, and how does that measure up to what is the actual reality on the ground and going forward? Yeah? Can
I ask one question, then we just open it up? One of my bugbears, because I have several bugbears, but one was around the use. It's the use of the data from the other side, because what we don't want is to build a beautiful data set that and there aren't enough analysts or enough people who know how to do good research to do it. So how do we know through the Pathfinders that we'll be able to actually, this linked data will tell us things we don't know, because it shouldn't be a theoretical exercise.
Yeah, and Phil's quite right. I didn't mention that in this first phase, we're absolutely going to require any authorised research to come into the safe haven, so that the data will be held in a secure facility and not allowed out. But a very important part of that will be to try and demonstrate real value there and then from what linked data can deliver. So we're working with a variety of bodies, the Royal College of General Practitioners and others, to sort of work out a programme for what sort of research we might do on that limited group on that data that flows from the first practices. Just to really reassure people that the benefits we're describing are achievable through the relatively simple but vital act of data sharing between general practice and hospitals.
Okay, great. Should we just open it out? Can we go back and then come forward to...
Yeah. My question would be...
Oh, sorry, for the sake of the people on the web, we need to use the mic.
Oh, you want me to start?
No, start, gentleman behind.
Is that working?
Yeah.
My name's David Cartwright. I'm from Oldham in Greater Manchester. My question would be, you start the Pathfinder, you collect your data, you then disseminate it, and look what's good, what's bad, what needs to change. How do you then relate that back through NHS England to the commissioners of those services, whether it be primary or secondary, and then how do you put that information back to the general public? Because in the past 5 years, we've had a lot of bad information saying, well, we've looked at all the information and we've got to do this. And I believe from what you've just said, nobody's looked at any information. It's just a case of, we'll dip in the pot there and we'll do something over there. So we've got to keep the trust of our communities. How do you intend that to happen?
Should we take the second question as well? Thank you. Yeah, it'll come on, yeah.
Yes, Brian Todd, Blackburn with Darwin, and victim of this scheme. The CCG in Blackburn with Darwin last week said they'd heard nothing about it from anybody. I don't know whether they're telling the truth or not, but that's what they said in a public meeting. My doctor says he's not writing to anybody because he hasn't heard from anybody on Wednesday of this week. So how is a pathfinder, are we a pathfinder? Nobody seems to know anything about it in Blackburn with Darwin.
Perfect.
Yeah, oh, sorry. Yeah, okay, sure. The way this will work is that the data leaves the general practice and has on it a number of identifiers. It doesn't actually have your name and address for the most part, but it will have your NHS number and other identifiers. It then goes into the safe haven, this secure facility where it's linked with hospital data. It will then be made available after analysis has taken place at levels of aggregation, so it won't be in any way identifiable to local commissioners so that they can start to test the degree to which it is useful for them. And then at even higher levels of aggregation, be eventually publishable to the general public so they can, for example, look at the comparative quality of their local general practice. Or one of the big issues here is we don't really have terribly good insight into the quality of general practice by local practice, and we want to build our awareness of how we can support GPs better by having that kind of information. But the public will also want that information, so we will be able to over time publish that at levels of anonymization, or levels which are anonymous enough to be published. And that's, I know, but I don't know if people understand the word aggregate, but at aggregate level. So exactly like statistics. So there's sort of different layers that goes from actually identifiable, which is only allowable in the secure facility, up to anonymous, so that it can actually be published in a newspaper or on a website.
Yeah. But I'm hearing a plea for using the data for benefit, I think is the other bit I think I heard you say as well.
Yeah, the big part of it is, once you've collected your data, analysed it, how will you use that then for the commissioning of services?
Yeah.
How are you going to say to a group of, or a clinical commissioning group in Blackburn and Darwin, what you need to do looking at this is that, how is that going to provide better services?
So one of the so apart from the fact that we just don't know certain things at all, we also can't provide commissioners, CCGs, with the ability to compare how their local service is providing, say, compared to a similar local service with similar kinds of patients, with a similar local population. So in order to enable a commissioner to have a sensible conversation with a local provider, they need to talk to them about the degree to which they are comparing well or not well with some other similar sort of environment. That's how you do commissioning. And at the moment, we cannot provide that data to them. This programme will allow them to have the tools of comparison with which they can have the kind of conversations that will actually drive both better quality and more effective care from local providers.
Yeah. Can I give an example that might help from my past, which was, it was a research project with a thing called the GP Research Database. And what it did was it looked at people with cancer who were treated 20 years ago and found that women who had breast cancer 20 years ago had double the risk of a heart condition. So what the commissioners were able to do was to go back to the GPs and say, when you have women who were treated with breast cancer 20 years ago, it's even more important that we have a conversation around, making sure your heart is healthy, so be aware of it. And look, so for me, part of the answer has to be real practical things, insight that people see out of the data, and it plays back into the health of the community. Because one of my issues in the early days was there was a lot of talk about this is great for UK PLC. Well, who on earth is UK PLC? How is it going to improve health in my community? So it has to be, and that's really why I worry about making sure we have the analytical capability, which then goes back to the commissioner. That would be one example. Sorry, we need to pick up the question on Darwin and have they heard or not?
Blackburn with Darwin, they denied it last week.
Yeah, I think with the Pathfinders, what we found is because they're all quite different sizes. So, for example, in Leeds, we've got 3 CCGs working as one citywide, whatever the collective noun is, conglomerate, I'm not sure. Whereas Blackburn with Darwen is obviously a much smaller CCG of 29 practices. So the Pathfinders are going at different speeds. What we found with Blackburn is we started off with all of the Pathfinders with initial conversations with chief officers, clinicians, to talk about the benefits of the scheme, to talk about how vital it was that we actually tested with Pathfinders and we had an open and honest conversation. So at BWD, we had that conversation, both with the chief officer plus with their GP clinical lead. And they said, yeah, we think this is something that's interesting. We think we can add value to this and this will add value to us. They've done a session with their clinical senate, which brings together all of the GP practices. I've done a session with their local medical committee to provide some background. And we had a launch event on Tuesday. And sorry, it's been a long week. My colleague's nodding in the background, so yes, it was Tuesday. Where we expressed an invitation out to all of the practices to come and hear what was happening and to ask any questions that they might have. What we haven't done at this point is definitely signed up practices to say, yes, we will become Pathfinders. And what's happening in each of the areas is they might stage this slightly differently, but the main theme is it starts with an evaluation of the materials, what we call co-production. So the kind of thing you see here, this is a blow-up of the leaflet that will be going out, series of GP and patient FAQs, that kind of thing. That's being shared with interested people across the CCGs to evaluate. We will then ask practices to express an interest in coming forward and taking part in the next stage, which is what we call fair processing. That's where we support them in contacting their patients to say, this is what we're talking about, this is what happens to your data, this is what we'd like to test, and giving them the information that allows them to make an informed decision whether to opt out or not. That stage hasn't started yet, but at the launch event yesterday, we didn't actually ask for practices to sign up. We're not at that stage with them yet, but we did have 3 practices that came forward spontaneously and they said, yeah, we want to test this, we want to be part of it. My colleague Simon on the table here has also been at a CCG breakfast meeting this morning, and not just because they tempted him there with croissant, to talk to the CCG staff and explain what's happening, because the CCG staff are also patients. It's also their data. And if we're going to help people to understand what's happening, if we're going to really test this out, these are the kind of people we need, and we need to get their views back.
When you announced it as a Pathfinder, you should have done all that before you announced it so that people knew. CCG refused to do anything about it until they get details from you. So the patients are sitting in the dark.
Each of the Pathfinders is building, in conjunction with their local health watch, is building an engagement plan, and it's set into that process. So the CCG have agreed that they will be Pathfinders, but what they've not done is mandated engagement with their GP practices, nor have they, as yet, asked each individual practice to make a decision about whether they take part or not.
Not what they said last week at their CCG meeting.
Okay. Sounds like that needs to be taken away. Thank you for that. Can we go to the lady at the back and then the gentleman here? Thank you. Oh, I'm sorry. Forget about it.
I'm Susan. I want to know if any other country has anything like Care.Data. If they do, how it works, and are you actually going to share this data and their data?
Good question. Gentleman here, and then gentleman here.
I just wanted to know how this is tying into the other availability of data that's available, because it might help you. I've been analysing the National Diabetes Audit, which has 2.1 million patients in it, and which shows the results, and I can tell you what happens by GP practice, not just by CCG. I can see what happens in hospital. I can see audits of patients coming out. So it's very valuable, very useful, so I support what you're doing is my key message. But the point is, you can analyse that data, and if you look at that, it's all held up by HSCIC, the same organisation that's holding your data. GPs get QOF points. You can dial that up and you can see that at the level of a CCG. Public Health England have just 2 weeks ago released a tool for a number of diseases whereby I can actually see, I'm working with Trafford CCG, I might add, you can see in the area how each GP is performing on each of the QOF targets on diabetes and a few other diseases, I can't remember which. But there are data sets out there which you might care to draw on to try and show how your wider scheme would be advantageous. And my real question was, how are you going to link it all together?
Gentleman here in the front.
My name's Bill Hodgson. I'm a member of the Civil Service Pensioners Alliance, an organisation of some 60,000 strong pensioners, significant users of the health service. It seems to me from what's been said tonight that this Pathfinder process is already falling apart at the seams from what Brian Todd from Blackburn with Darwin has to say about the mystery that seems to be surrounding their involvement. I spent 2 hours or so watching the webcast of the last meeting of this type, and I'm still not clear on the process of how the Pathfinders were chosen. Seems there's something odd going on there. How can we be sure as members of the public about the balance that exists in these organisations that have been chosen? Are there sceptics there? Are there dead keen groups there? Why has it been done on a kind of geographical basis rather than types of patient and condition? I ask that because diabetes has been mentioned, and that is a major problem, and you could be looking at what's happening with the 2 million or so people who've got diabetes type 2 in this country. But I'm not convinced about the Pathfinder process, and I'm not convinced about how the people were chosen as to whether they're truly representative.
Great questions. There's the international bit, there's other data sets, and then how were the Pathfinders chosen?
So there are some other countries that do this. They're much smaller than us. So Sweden, for example, does at regional level have this kind of data sharing arrangement. But there's no one who, as far as I'm aware, Phil may know differently, who has proposed a data linkage scheme on this scale before. So one of the other reasons why it was appropriate for us to just pause when we had the criticism originally was because actually there is no roadmap for this kind of thing, and what we need to do is just make sure that we help not just ourselves get it right, but actually there's a lot of international interest in how we manage this moving forward. And oddly enough, I was in China a couple of months or so ago, and the provinces of China vary in size, but they're sort of English. They're 60 million, 100 million people. They're sort of English, UK-ish sort of size, and they are all very interested in how the conversation can be managed and developed and open about this kind of data sharing, which they also need for a whole variety of obvious reasons to support their own local populations. So we're being watched in that respect. There's certainly no plan to share this data internationally, nor, to be honest, other than when it's fully anonymous, I can't properly conceive of a situation in which that might occur without consent, that is. Of course, if people want to consent to their data being shared, that's different. The point that was made about link, well, of course, I'm a huge and massive advocate and of clinical audit data. For those who understand what that is, this is a product of different clinical communities who have got together in order to, in a way, fill this data absence by recording data for themselves, doctors often running it directly themselves, and building very, very rich resources for the improvement of patient services as well as research. I think partly Care.Data, though this is a long way beyond where we're at the moment, leads us in the direction over a number of years towards a point where we hope there will be a very comprehensive environment for data sharing, which will sort of be able to answer all those questions, not just about the big diseases. So I agree, diabetes is a very well covered area, but one of the big areas we're going to have as we get older and sicker and our generation in particular likely to impose a burden on the health service way beyond the burden the health service is currently experiencing. There will be an awful lot more people with very either not sort of rare singular conditions brought about not because they have so many multiple conditions, and there are some really important reasons why we need to be in a much better place to understand what happens to small numbers of people as well as large numbers of people. But certainly support the view that at the end of all this, hopefully we can get to a linked environment which will service all patients. On the question of how the pathfinders were chosen, I think we've been very transparent about this, so there's certainly no secret. We excuse me, put out a call to action to CCGs. The NHS is obviously under enormous pressure at the moment, and we didn't want to sort of force any CCGs to participate. 4 came forward. We decided we were going to have somewhere between 100 and 500 general practices as a total, and so we turned some down. But the 4, we had an independent panel that reviewed the selection of the CCGs for this process, and that panel decided that what it wanted was a mix of rural and urban CCGs. Certainly, there's no question that amongst the CCGs that have been selected, there are GPs that are very different mindsets around this programme. So I can't give you the figures, but you know that they are representative of as it were, the community of clinicians, and that's a very important part of it, because what this is not some sort of token experiment. We need to understand where people have issues, what we can do to resolve them, and it's a very important part of the programme that we do have GPs who are not necessarily supportive, so that we can work out what we do with that.
You're not mandating any. Our understanding is you're not mandating any particular practice.
No, we're not.
To be in.
Yeah.
So it's likely that the sceptics won't be.
Well, I'm not sure. At the moment, it's not. There are some sceptics who are definitely absolutely wanting to be inside it because they want to. For various reasons. Yeah. So I don't know, but I think it's all part of just having an open and transparent conversation and process. But just to reassure you, there was an independent panel that adjudicated on the selection of those CCGs.
Brilliant. I've got a question from Twitter. I'd quite like to log
Twitter
in.
and the gentleman here.
Okay, so the question from Twitter was, if someone actually opts out of Care.Data, what information will still leave a GP practice?
And can we take the gentleman there as well?
Right. My name is Geoffrey Ron. I'm representing Health Watch Bolton. We're moving into a period, well, the future lies with integration of medical and social care. Yeah. How are we going to deal with the sharing of data with, say, local authority social services?
Let me just answer the opt-out question. So Phil's more an expert on this, but I'm not going to get... Essentially, there were, rather confusingly, originally 2 types of opt-out proposed. There is now just 1 type of opt-out proposed, and as of very recently. And what that means is that if you elect not to opt out of this project, then no identifiable data will leave GP practice. Full stop. That's what it means. There are occasions when data that's derived from your record but is not identifiable might flow. So, for example, there will be a count, probably, of the number of people who've opted out without any identification of them, so that we can monitor the degree to which actually one of the things that Med Confidential wants to do, monitor the number of opt-outs, for example. But there will be no identifiable data that leaves the practice if you opt out. Second thing...
Sorry, the thing that we're being asked as well, that original 2 opt-outs, the original 2 opt-outs said, and certainly earlier in the year, the concern was around what was being done with the data from hospitals as well, which is why it was being, we think it was being offered. Yeah. So this is, the opt-out now, is it going to do anything about data gathered from other sources, or is it only going to be the GP practice? And those people who've already opted out and said, I don't want my data being passed on by the Health and Social Care Information Centre, when will that be actioned?
Yes, right. So of course there were some people, we actually don't quite know how many, but a small number of people who in the first iteration of this programme opted for their data to leave the GP practice, but for it not then to travel to certain uses outside of the information centre, if I can be. And the fact that we're now changing the opt-out to be much simpler and basically just give you the choice of either it leaves the GP practice or it doesn't, leaves us with a group of people to whom we need to go back and invite them to make when we get to ask them what they would like to do about that. So that's the point I think you're making, isn't it?
It's that you've talked about sort of hospital and GP, and we're talking in the narrow confines of the Pathfinder stage now. But there is a broader picture, which is that data is gathered from hospitals.
You're right. No, you're right.
It'll be gathered from pathology labs. It'll be gathered from a whole range of sources. And it's all very well to have an opt-out that operates at your GP practice. And like I say, we're satisfied if no identifiable data leaves. And I think most patients would say, OK, that's fine. But what about my data from elsewhere?
So at the moment, it's in relation to the current GP practice. But you're absolutely right. One of the longer-term, medium-term issues that the NHS has to deal with is that this opt-out is government policy. It will need to gradually be applied to all other patient data as it exists in the health service, and we need to work out how that all works. But for now, it's the GP issue. The integration of probably the most important argument for Care.Data is that it's how we can ensure properly commissioned and well provided integrated care services. It is through the ability to link data across different pathways that we will be able to design services so they offer a much more integrated experience to patients, which is, I think, one of the most important contributions we are going to make collectively to an improved sustainable health service, as you've just said, in in our lifetimes. The issue, one of the great, one of the extraordinary assets of our health service is the NHS number, which is, we are given at birth, and the ability, we are already able, in some places, to link data across the health and local government border by using that identifier, so that there's a common currency, if you like, of identification which enables us to do that. Now, we need to step carefully in that direction, but I think one of the points that Phil is just making is that we do see eventually a situation in which this does go beyond GP practices and hospitals and does start to look at care homes, community-based services, in all sorts of... And at each step of that journey, we're going to have to seek people's permission, and we're going to have to work out what the safety implications and security implications are. But I hope you'll recognise that we are trying to do this in a way which just minimises the rush and the risk in order that we get those questions right. But there is no doubt that if we do not, in the end, have the ability to sort of link and understand what happens to people as they travel, not just within health, but also within social care, we will not be able to provide, I don't think, services personalised to need in a way which we must have an ambition to do.
Are the local government association involved at this stage?
Yes, well, certainly local government is absolutely involved. And in fact, local government often is often a better user of the NHS number than some NHS services. So
can we take one more question and then we'll move into the table? Gentleman here. I feel rapt attention.
Dr. Amir Hanan, I'm a GP and CCG board member for Tameside and Glossop, leading on long-term conditions, information management technology and patient engagement and patient empowerment. Thank you very much for the talks and for helping us to understand what Care.Data is about. Tameside is interesting because it's the capital of heart disease in the country, so I was really interested in the points you were making about how Care.Data might be able to support our patient population. Our patient population is dying 10 years younger than the national average, and as the CCG lead for long-term conditions, it's very close to my own heart personally. However, what we do also know is the reasons for why there is so much heart disease in Tameside is actually a lot to do with lifestyle. A lot of it's to do with smoking. We've got very high levels of smoking, and although over the last 10 years we've reduced the amount of smoking, so has everybody else, so we're still lagging behind. And there's a lot of data already available, a lot of information, actually, knowledge available locally amongst clinicians in primary care, secondary care and public health who actually know what the challenges are and how we can actually reach out to people. And it's about changing their knowledge. It's about health literacy that's key to changing it rather than necessarily the data itself. However, as a commissioner, of course it's in my interests for the data from GP practices and hospitals to connect together. And so, yes, absolutely, I actually want that connection of data to happen. However, we also want to make sure that that data quality is good, and we know that if it's QOF data, it's very good because, you know, we get paid for it, and if it's non-QOF, then it's dodgy at best because we don't get paid for it, so it varies. And the patients and the public are really worried. As you know, I champion patient access to the GP record, and yesterday a patient signed up for access, but they asked the question, they said, is anyone else going to be able to look at my data? Middle England is frightened to death because they're saying it's fine if it's my data, but if other people are going to take it, they're not happy about it, whoever those other people might be. Just because I'm a GP doesn't give me a personal right to be able to see your data, for instance, unless, of course, you've collapsed and I need to know what's going on. But I want to finish on a positive note because, as I say, as a GP commissioner, I do want that data connected. I do want to improve the quality of the data. And I believe that the nation's mood is now changing. More and more people want to be able to access their own data themselves. And if they can access their own record, and then if they're convinced by the benefits of what you're talking about, why can't patients themselves, through an explicit consent process, push that data up there? Because I actually feel that people, when they're asked, will do the right thing. But if they're not asked, you're in the situation that you have at the moment where 11% of my patients have opted out. And interestingly, 58% of them are people who've got access to their own records. In other words, the very people who you would expect, who know their own data, are the ones who are choosing to opt out. And that's a terrible place to be and not something that I'm particularly proud of. But it really shows that turn it around and let's start talking about an explicit consent process where the patients are actually asked and the public are asked to send their data. And I think if you find that if you do ask people that, they'll do the right thing. But if you don't, then don't be surprised if more and more people opt out.
Tim? Or
well, I think that's a perfectly legitimate view, the reason that it's not at this point, you know, that it's not sort of now what we might call an opt-in, if that's what you're referring to, sort of explicit consent, is because everything we know in the NHS about opt-in is that it drives inequality of outcome. So one of the issues, and we've debated this a lot, as you know, the BMA and various others have called for this. We need to know most, in a way, about the people who are least likely to opt into a scheme like this. It is precisely the people who need the services most and don't get them, and those people who would least likely be an active participant in, say, a current patient record access scheme. You know, I'm passionate about that as well, who actually we need to have, in a way, the most intelligence about. So there's I think, for me at least, a very strong moral argument for the way in which we've currently configured this as an opt-out based scheme. However, in a way, both of those kind of thoughts become a bit irrelevant if we really do communicate with everybody about the opt-out. So when you dig into some GP's concerns, as yours, about the fact that people really must know to make a decision, the emphasis then becomes on how do we really properly communicate with people in order that, in a way, the opt-out, opt-in issue becomes less relevant if we can have confidence that people across the piece are aware of what's happening and therefore able to make a judgment, even if that judgment is they don't do anything and therefore essentially don't opt out.
Phil?
Just very quickly, because it hasn't been mentioned, but one of the important things that came across was people need to know where their and their families' data has gone. We proposed, and we believe it's rolling, so I'll mention it in this context, a personal data usage report. It's a bit of an ugly term. I'm sure it will come up much more polished. But the idea is that you actually would be able to get, like some sort of statement like you get for your mobile phone or your bank, and will be able to know where your data has gone. Patient Online is, 2015, and rolling out from that point on, and hopefully that will link up with people's consent choices. But it's really important, not just to sort of publish and say, oh, well, we're going to be doing a bunch of good stuff, and, 3 months or so retrospectively say we've given some data to some people. Patients actually want to know, and I think what I'm hearing from what you're saying there, is that patients want the confidence to know exactly who's had access to their data. And I think everything that should come out of this process should be about building patient confidence through knowledge, not just having to sort of trust some statements, but to actually be able to see it. And that's what we hope will come in the future.
Okay, brilliant. Need to move on to the table conversation, but thank you for that. Hope that was useful and helpful and interesting. And what we're going to do now is talk about the proposed solutions to 3 of the problems that were on that list up there. One was around the secure data facility, how will the data be protected? Second one was who's going to be able to see this stuff and what they're going to do with it. And the third one is and how some of that communication is going to happen, if that's okay. And then we'll come back at the end of that, have a bit of a conversation, and we promise to get you away by 8. Thank you. Thank you.
Feel free to move around and
For those of you watching on the webcast, we will be returning at 7:30, so in 20 minutes' time. Please do join us for the continuation of this Care.Data event. Thank you. At this Care.Data event here in Manchester, we're still taking part in table discussions. We shall be resuming in about 4 to 5 minutes. And the questions on the screen that you see at the moment are the questions that the tables are discussing.
Okay. Yeah. Okay. Really sorry to interrupt. It sounds like.
To interrupt unsuccessfully.
Interrupt unsuccessfully. Hello? Can I?
Okay, we're about to take feedback now. It'd be really helpful if ideally facilitators or one person per table was in a position to give us some feedback. I'll hand back over to Kieran.
So we're going to try and take 3 points from each table, and if we try and do it as succinctly as we can, then we'll all get home and out the door at 8 o'clock, and hopefully have a little bit more time at the end for any burning questions, things you'd still like to say.
Yeah, and we will be capturing everything, and the people at the table from the programme and for the advisory group will have been recording everything, or writing everything down, not tape recording you. So we will collate all the information, and we'll produce a bit of a report, which won't try and be verbatim as well. So, just because you give us 3 things doesn't mean we won't capture everything else you said as well.
Rachel, do you just want to say very quickly about the follow-up and the report and what we'll do after today in terms of information?
Yeah, absolutely. Up until, for every event running up to today, everybody that's attended or expressed an interest, we've added to a list, a circulation list, so that you'll automatically get all the information that comes out, unless, of course, you opt out, in which case let me know before you leave. But you'll get all the information. We'll make the slides available. You'll be sent a link to the slides that you've been shown tonight, and you'll also get a report from today and a link to the webcast if you want to go back, review some of the conversation. I think there will be more information coming out gradually, and we'll use that as a mechanism to continue to circulate. If you have questions after you've left today, and there are still things that you think, I should have asked that, then please just, when we send the link out to you with the slides, come back to us via that. We'll send you a response, contact details, and you can feed those questions through us, or obviously you can continue to use the Twitter feed using Care.Data as a hashtag, and the questions will be picked up there, or you can go directly through to the team. But happy for us to route those through and make sure you get a response.
Fabulous. Let's try and do some very quick feedback. So, you want to go first? Cool.
So 3 issues. 1, trust, which was going to be said 3 times. But second was communication, and the third was to give Dame Fiona teeth through statutory powers.
Yep. And for those of you who know Dame Fiona, yeah. No, she's formidable.
I'm going to go this one.
Thank you for those.
3 key points. One was about the priority, about the ability to access the data and the dissemination of the data. That seemed to be really vital, and it felt like you had to just go to a secure place, and that's a concern. Concern about the legalities of GPs releasing data under the Data Protection Act, and questions about the quality. Is the quality sufficiently detailed for the benefits that were being aimed for from the GPs? Because it's not coded.
Yep. Data quality came up earlier as well.
Okay, lots of questions, lots of comments, but 3 things just to point out. We had a really interesting discussion about, is there an appetite by the public for themselves to push information upwards, and will that be more useful? It's easy to connect with the public, and it's that thing of people wanting to tell their information. There is a very clear question of what's changed as a result of the pause, the 6-month pause. What's actually changed, and also lots of practical questions still around things like, how large is the data set? What coded information will get sent? Some very practical questions like that.
Okay, thank you for those.
Yeah, really good discussion on this table. We sort of concentrated more on the communication and engagement angle. Very much thoughts about how important the communication needs to be in multiple languages for as many people as possible, and really casting that net as widely as possible when it comes to engagement. And also a question around, are the programme linking into already established hard-to-reach group networks at local level and also at a national level as well?
Okay, thank you.
Can I just add to that? Certainly my concern was that the communication engagement strategy could be quite fundamentally flawed. There was some discussion about whether it actually was engagement or just informing people, and whether it was real consultation. That's the first point. But there's a huge body of evidence and experience around community engagement from years ago. And one example we were given was about how, in order to engage women from some BME communities, you talk to their male partners. I mean, this is shocking to me because there's been a loss of alternative ways of engaging with women, which supports their rights as women to keep certain things private and not have to share with their partners. There's also a lack of awareness generally in terminology and around the social model of disability and issues around disabled people. And there are other communities. I mean, we didn't even start talking about issues for people with mental health issues. And I think, you know, that the whole thing seems to be the wrong way round, really. You know, all this information is going out to the Pathfinder communities. There's no legal protection for those people in those communities at the moment. You pointed out that the legal standing's not clear. And the engagement strategy that somebody talked about, or the communication strategy, is still being worked out. I also raised issues about, because we were told that some disabled people's organisations were already being consulted, but nobody knew who they were. And are they organisations of disabled people or organisations for disabled people, like RNIB and RNID, who may have people representing disabled people but not themselves disabled people? There are differences in the way some of these organisations approach issues. So those are just a few issues that we raised.
Thank you. Table behind.
Okay, so I think on this table, the 3 points that we covered, one is that people here are actually staggered by what we don't know, which I think, and another key point was that actually, if we're going to pass on data, patients need to have control of their own data so that they can check for accuracy and know what's being reported. And then the third thing is that if we're reporting, that all demographics and all characteristics need to be reported, including sexual orientation monitoring, because if you're not counted, then you can't be counted. So it needs to cover everything.
Thank you for those. Are we coming across?
So we looked at the approach to communications and we said that we can't just give people a leaflet and assume that they'll understand that leaflet. So it's about talking to patients and sort of within the Pathfinder areas, we need to sort of get out and talk to people and sort of understand their concerns and check that what we're saying is making sense to them. Then we also talked about the access and data use and said that we need to be clearer about who will use the data and what benefits will come from different people having access to the data. We also said that there was concern that some companies have two sides of the business. So where we're saying that companies will only have or people will only have access to data if it's for the provision of health and social care or benefit the provision of health and social care. There's kind of just a bit of sort of grey water around that, and we need to be really, really clear. So I think that's some feedback for us to take back. Did I miss anything?
Agree with that too. Thank you.
No? Okay.
We had similar issues or points that we'd raised, and the main one I think was around thinking about how the process around the data needs to be more two-way. So It's about how the care data research can be fed, the successes can be fed back to individuals, and patients can get a sense of how the data and care data is actually helping improve matters, and then get a sense perhaps about the role that their illness has played in helping that. So following on from that, is that part of the timeline, and would that be ahead of, or could that be ahead of opening up the access to the data to more approved providers or research agencies? So as part of a kind of safeguarding procedure, you get a sense of why people are accessing it and what difference it's making, and individuals get a sense of that this is a good thing and their role in it has played a good part.
Great. You're done?
Are you done?
Yeah.
Is that everybody?
That's everyone.
Cool. So, I'm going to give the panel a little bit of a chance to respond to some of that. Now, I was just listening in there and we've captured everything, but some of the key questions that I heard there, one really important one is around what's actually changed as a result of the pause. So I wonder if that's something we could ask the panel to respond to.
Yeah. So I heard a lot of things there which I think were really helpful and thoughtful. Actually, really quite a lot has changed in the last 6 months, and that goes right back to the fact that some legislation was rushed through in something called the Care Act back earlier this year. And what that did was give statutory authority to the body now charged with determining who can have access to this data. So there's something called the Care.Data Advisory Group, which is independent of NHS England and of the Information Centre, which now has statutory authority. It has existed before, but without statutory authority, to determine essentially the process by which different organisations, NHS bodies included, will be able to get access to that data and to police this vitally important definition of what health and care means in relation to the uses of that data. So that's, I think, a very important step forward. So for the first time, we have statutory independent oversight of the way in which health data of this sort is used for the right purposes. The second thing is that the government, and I'm obviously not the government, but in a way just speaking, the appointment of Dame Fiona Caldicott as the National Data Guardian is the intention of the government to give her statutory powers in order to force people to comply with her recommendations, probably around best practice and the way in which individual organisations should safeguard data. So we might consider her to be something like a chief inspector of confidentiality, and that will have statutory basis as soon as there is a legislative frame for that. So I think those are two very important differences. I think possibly in many ways the other key thing that's changed is the way in which the Information Centre is now committed to a code of practice to be completely transparent about the organisations that are given access to this information, so that we can see who they are and what they're using that data for, and indeed in certain circumstances when required by the Confidentiality Advisory Group, those organisations will also be subject to independent audit. So this is a pretty thorough and detailed process that's being proposed, and there are some new sanctions for people who do not show the kind of responsibility we would all expect in relation to the handling of our data. And the most important of those is, in the context of the new Care Act provisions, an organisation that does not deliver on the requirements it will have for handling this data will be barred potentially from ever using the data again. So a one strike and you're out policy is also part of the legislative intention. That is a very, very draconian requirement and sets a new bar, I think, globally for this kind of consequence that will befall an organisation in relation to bad handling of patient data. I'm sure Phil will also suggest, which I agree with, that there should be sanction, a different kind of criminal sanction. There are already, of course, criminal sanctions for people who try and re-identify data, but at the moment those are not custodial. So there's an area there which I happen to agree with in relation to the government considering additional custodial sentences for anyone found to have the intention of re-identifying a patient in this context. So those are some things that have changed. I don't know if Phil wants to...
Yeah, well, I mean, they're changing. We have not seen the rules around CAG, the regulations. We haven't seen the definition of emotional health. We haven't seen the one-strike sanction. These are all good proposals. We need to see them. We need to see them in place. And if you're going to communicate to patients about it, then obviously that's an important part of building trust, that they're there.
And actually, just to say, sorry, to go to the point somebody made. So the Pathfinder process, so at the moment we're in a developmental stage, that will not proceed to action, i.e. literally the fair processing period and then the extraction until these legislative provisions are in place. So just to give people the reassurance that these rules will be completely known and have been laid before Parliament before that process begins.
Yeah. And then sort of moving forward, I know we're talking about a Pathfinder stage here, but undertakings are being made about, we're writing to every, the programme is writing to every patient with the leaflet that we're seeing, or a version of the leaflet we're seeing, and an opt-out form. This has to be true going forward. You can't do a bunch of things for a Pathfinder and that not be the case as you go forward. So, if you're making assurances on that basis now, like your data will never leave a secure data facility, people have to know, if they're being given a choice right now, that that's going to continue to be true. So it's that sort of thing.
On your tables, you've got some copies of the opt-out form and the letter as they currently are. So if you want to grab those and scribble on them and hand them in to us, we can take some of that feedback.
And can I just give an observation from chairing the advisory group as to what I think might be different now to 6 months ago? One is it's much more about co-creation. So it's the reason, it's almost the reason around, sort of the question about how come we don't have the answer to some of these questions, because actually we're developing the answers with people out there in a way which probably wasn't done previously. So that's one. Second one's a boring one, but I think the project is better resourced with, more people, different people, additional people, whatever as well, which is making a difference. And the third one is, and it kind of links to the first one, is saying that there's a realization that this program in itself is almost a pathfinder, because it's a question about where's the future around integrated care. So if this program doesn't get it right, it's actually setting a bad precedent for lots of other things as well. So I think there's a lot of care being paid to this, because actually there's a bit of this which is addressing the sins of the past, and there's a bit of this which is trying to work out, because whatever Care.Data ends up doing will actually be applied to lots of other things as well. So it's very important to get this right, I think. That would be my other observation. Happy to be... Sorry?
Forgive me, I was going to say that's good with the understatement.
Yeah, no. Agree.
Given that, as you said, nothing will happen unless Parliament agrees to it, do you think it would be helpful for the public at large? And I'm very aware that the public weren't able to come to this meeting. You had to be...
No, they are. Yeah, absolutely.
It was. But the question I was going to ask was, do you think it would be helpful for the public to actually meet with their MPs or prospective MPs to ask them what their views are and put it on their manifesto, so that there's an opportunity there for the public to be able to sort of discuss it with their MPs, given that they're the ones who are going to decide whether it goes forward or not?
Well, I mean, I believe in democracy, and of course people should be able to and should do absolutely that if they want to. I'm just to make a point, though, about the democratic process that's being pursued in this case. The Parliament has already expressed its will in relation to the Care Act, so we're not actually going back to Parliament to ask for permission on the regulations that flow from that decision by Parliament. The regulations need to what's technically be laid before Parliament. They won't then be debated by Parliament, but they need to be laid before Parliament. So that's just to make that technical point. So essentially, Parliament said these are its intentions, and in a way, it's down to people like Phil and hopefully myself and others to make sure that that intention is realised in the regulations that follow. But Parliament itself has expressed its intention, which is as we've just described.
But Parliament in 6 months might abandon the Care Act entirely. I understand. That's what one party is saying.
Could I just make two last points I know we're about to finish, aren't we? So there are just 2 points which I think are very, very important, which are a whole different conversation. But just to make it, so NHS England is absolutely committed to giving people access to their own data, and we are very, very strongly prioritising that happening in reality. Because I completely agree with everyone who said this, that on the one hand we can't expect people to share their data for these important purposes without at the same time having access to it. So these two things are aligned, and I think this conversation in many ways will get easier, although more complicated, as we ourselves become master of our own data in a way that just hasn't happened before. And the second quick thing is to say that it is also, we are committed to giving people proper transparency, as I think some of these documents say, to ways in which their data is contributing to the benefit of others. And it's actually, as I think a lot of people here know, that's quite technically complicated to do, but it's something we are set on delivering, because it seems to me absolutely right that people should, in a way, be able to audit the way in which their data is delivering benefit from its sharing.
Thank you. Rachel's been waving at me for about 10 minutes, so I'm just going to give her a chance.
Just that we've had a request from people watching on the webcast to know where the leaflet is, and we'll send a link out to it ASAP after today, so everyone gets a copy of it. Photographs have been taken of it, and you can view them on Twitter, but they won't be as good as.
Yeah. Just to say, it's a draft leaflet as well. It's in production.
Yeah.
Sorry.
Just an obvious question. Can it be made available in alternative formats for disabled people?
It will, absolutely. No, there are lots of patient groups being involved in the development.
That's one of the things
them.
that's happening at the moment.
And gentlemen here, and then I'll have the last word, and then we'll have you out by 8.
Sorry, I don't mean in the future, but for people's comments now. Yeah, thank you.
I think the other thing is to try and assure you that a vast majority of older people do not have access to the internet because it's too expensive. Do not expect everything back by bloody internet, please.
Correct.
One of the things we're really focusing on in the Pathfinders is how we communicate to people and work with people that wouldn't access mainstream internet, all those things. So.
Yeah, brilliant. But a good reminder. Okay, it's just about to strike 8. Thank you again for your time. Hugely appreciated it. Phil and myself, on behalf of the advisory group, we'll be going through all the comments, all the stuff as well. So thank you for that. Programme, of course, is here as well, so they've heard it directly. And rest assured that when we get the feedback from the programme as to what they think is, we'll be playing this tape through our heads and saying, is that consistent with what we heard in this room today? So thank you again for the time. Really do appreciate it. Thank you.